we're starting a little late, but I think we ought to start because it's getting late, and we want to give everyone the opportunity to present his topic. My name's Sebastian. I'm going to chair the session a little bit. So this is a special session where everyone presents his topic for 5 minutes, and then we will have a discussion in the end. So if you have questions to a certain presentation, please maybe take a note so you will remember it when we can discuss it afterwards. Okay, so I'm going to ask the first presenter, please come on the stage. This one is about complementary and alternative therapies and strategies we can no longer ignore. Please. It's just gonna press play, I guess.
Hello everyone, my name is Ines Antunes, and I'm a resident of family medicine at o EPS Travessa da Saúde, which is located in Moura, just outside Lisbon. But it should go on.
It's okay.
So today I will tell you about complementary and alternative therapies, also known as CAM therapies, and why we should learn about them. I hope that...
Please use the mic because the colleagues at home don't listen to you.
I hope that by the end of this short session, I have convinced you that CAM therapies have a significant impact in healthcare today, that it is crucial that we learn about these therapies to help our patients. So you may be wondering what exactly are complementary and alternative therapies. The term CAM therapies is used for medical practice and products that are not part of standard medical care. While complementary therapies are used together with standard medical treatments, alternative ones are used instead of conventional medical therapies. The list of CAM therapies is extensive, but they can be broadly divided in two main categories. The first one are natural products, which includes herbs, probiotics, vitamins, and minerals, which are sold many times as dietary supplements. The second group are mind and body practices, which are techniques and procedures administered or taught by a trained practitioner. The most common ones are yoga, meditation, massage, acupuncture, and relaxation techniques. Today, many CAM therapies are used in the context of integrative medicine, which tries to combine traditional medical treatments with CAM therapies that have been proven to be safe and effective. But why should we care about CAM? Well, CAM is the fastest growing area in healthcare today, and around 1/3 of adults and 11% of children use at least one CAM therapy. And at the primary care level, the numbers are equally impressive, with 50% of primary care patients using CAM, and only half of them are telling about it to their doctors. So as family doctors, we cannot keep ignoring CAM. Why do people use CAM? The main reason for CAM usage is the lack of satisfaction with conventional treatments. Many patients feel they are over-medicated, they don't understand the reason for their medication, they feel they don't have a say in their treatment options, they may not tolerate the side effects of many of the drugs, and also the results with standard treatments are sometimes poor, and therefore patients turn to CAM therapies in search of better results. CAM therapies are seen as being more natural and effective by patients. Patients who use CAM therapies feel they have a more active role in their treatment options, and therefore they feel they are more in control of their health. Another reason for CAM usage is the satisfaction with the consultation, with CAM providers having longer consultation times, and also they are more keen on letting the patient talk and on examining the patient. Today, the main concerns regarding CAM therapies are the regulation of CAM professionals and how can we ensure the quality of the treatments and also the safety of our patients that decide to opt for these therapies. For us family doctors, one of the main challenges is that patients are not telling us about their chem therapies options because they feel it to be disregarded or disapproved. Another challenge is that we are not well informed regarding chem, and because of that, we are not comfortable discussing chem with our patients. But if we want to offer proper guidance and advice, we need to learn about these therapies and help our patients. So this communication gap between patients and their family doctors is an excellent opportunity for us. If we learn about chem and are able to discuss chem with our patients, it can lead to enhanced communication, satisfaction, and quality of care. So I have shown you that chem is the fastest growing area in healthcare, that it is used by many of our patients, and I hope I have convinced you that we need to educate ourselves and talk about it in order to provide better care. So thank you very much for listening, and I'll be very happy to discuss this topic with you.
Thank you very much. As you can see, 5 minutes are way too short to present all these topics, so I hope you can write down all your questions for the remarks in the end. And I'm asking the next presenter to come on stage. This one is about having a vegetarian diet during pregnancy and breastfeeding.
So, hello. My name is Rute Marques, and I'm a family medicine resident here in Portugal. So before we get started, can I just have everyone raising their hands? Hands up. Okay, so keep them up, and now answer me 3 questions. Who has never had a vegetarian or vegan patient? Put your hand down. Has never had a vegetarian or vegan pregnant woman? Put your hand down. Who has felt completely comfortable giving advice to their vegetarian or vegan pregnant women? Put your hand down. Okay, so we don't have a lot of hands up, but this is a growing choice in diet for our patients, and it's an important subject we need to talk about and to discuss in order to give the best advice possible, because it's growing not only in Europe, but in the entire world. So regarding the adequacy and safety of these diets during these very important periods of a woman's life, the American Dietetic Association and other associations consider that if appropriately planned, they can be valid options for pregnancy and lactation. But because we are talking about very important periods in the life cycle, and we know that the nutritional requirements increase, we have to be aware and informed of the risks and how to avoid them, because we are talking about restrictive diets. Before we continue, let's remember that there are different types of diets. Vegetarians that may drink milk and eat eggs, and vegans that don't. This is important because the more restrictive the diet, the bigger the risk for nutrient deficiencies. Talking of macronutrients, and for protein, we don't have to worry about it. Usually it's not a problem. As for fatty acids, the ingestion of alpha-linoleic acid is similar, but for EPA and DHA, it's usually low or even absent, especially in the vegan diet. As for micronutrients and for iron, its bioavailability in plant sources, it's usually lower. But there are still uncertainties regarding supplementation. Folic acid is adequate, but vegans seem to be at a higher risk for iodine deficiency. So there is not enough evidence to state that vegetarians have a lower zinc status, but they seem to be a risk group. As for calcium, its bioavailability may be affected by other nutrients, so it's usually found at low levels in the vegan diet. There seems to be some evidence of a lower ingestion of vitamin D, especially in vegans. As for vitamin B12, it only exists in animal products, so it's usually found at low levels, especially in the vegan diet. It's important to make a dietary assessment, taking into special consideration these potential nutrient deficiencies. A 3 to 7 day diet history is a good place to start. And please pay special attention to these nutrients, because we just saw they may be deficient. So this is an example of an education packet we can give our patients. It may contain food sources for specific nutrients, the expected weight gain according to the initial BMI, and some sample menus if you're bold enough, and of course, additional information on resources. The majority of the requirements can be met with careful dietary planning and the inclusion of fortified foods. This is the first step, really, but it would be nearly impossible to present to you all the available sources for every nutrient. But in these slides, you'll find good examples. Just note that some food types are richer, others have lower bioavailability. And for some nutrients, you have good natural sources, and others you can only find in fortified foods because they exist primarily in animal products. This may be helpful in order to give advice and to help our patients make the best option and have a richer diet. As I showed you before, it's good to have some written materials already prepared and available to give our patients. As important as to know which nutrients are richer in, which food types are richer in each nutrient, it's the amount of the intake. So we should advise our pregnant women to have a rich and varied diet, taking into special consideration the recommended number of servings for each food type. Regarding supplementation, the studies differ. As I just said, the first step is also to ensure the adequate intake of rich foods or fortified foods. Only if this is not the case should supplementation be considered. Yet, there is some concerns about the supplementation of DHA and iodine, especially in vegans, and some associations advise it. Unfortunately, we couldn't find specific recommendations for lactation, but we know that the diet should also be carefully planned. As family doctors, we should support our patients' life choices with a supportive and non-judgmental approach. We should keep an open mind, clarify any doubts, and give the most informed advice. It may be highly beneficial to have the support of a dietitian. The studies differ and the results and recommendations are heterogeneous, but this is a growing choice in diet for our patients, so we should keep the research in order to give the most informed advice to our pregnant women. Thank you for your attention.
Thank you for that good presentation. That definitely made me hungry for the next presentation, which is about palliative care and sexuality, giving life to a relationship.
Hello, good afternoon. My name is João Ribeiro. I'm working in Cabeceiras de Baixo here in Portugal, and I'm here to tell you a story about a couple who was being treated for palliative care in my unit. Okay, my work talks about palliative care and sexuality. First, I want to talk what is palliative medicine. In palliative medicine, we worry about quality of life of our patients. It's not only for terminally ill patients, but in patients and family as care as a unit and not as one itself. In our consult, we have referral criteria. We accept patients with congestive heart failure, with chronic dyspnea, with oncologic disease, of course, with dementia, with chronic obstructive pulmonary disease, and I think that's the most important of all, with patients ill, when they don't want to be cured, but want to be just treated, okay? And what about sexuality and what about sex? We can define sex just as physical act. Sexuality is the way each one lives her own sexuality. It varies for patients to patients and in a couple. What about chronic heart failure? Okay? We can treat chronic heart failure as palliative medicine when you have chronic dyspnea, when you have edemas, when you have nocturnal cough that doesn't let our patient sleep, the many rooms to emergency service, and I think most important of all is not right here, patients will again. Sex life. Chronic heart failure has really consequences in sex life. First of all, reduction of sexual activity, first because of dyspnea. Loss of sexual interest, less satisfaction, and incapability to maintain sex life. First of all, because of depression was associated. Physical abnormalities like erectile dysfunction because of less blood, less tolerance to exercise because of dyspnea, and less capable of arousal, one more time, because of depression. Breast cancer. Breast cancer has main cause of death in Europe. 5% was diagnosed under 30 years. There are two main types, lobular and ductal. In this case, the woman has lobular cancer. It has consequences in sex life too. First of all, because of self-image. My patient asks many times, how can my husband look at me when I don't have a breast? Hormonal changes also caused by the treatment itself or by the cancer too. Depression and anxiety, as I talked, is associated with breast cancer all the time. And the feeling of revolt, okay? My patient was only asking, why me, why not the others? And that leads to more depression, more anxiety, and more revolt, okay? And what about the treatment? We can deal with chronic heart failure by non-pharmacologic disease. We can first talk to our patient, set realistic expectation, tell them to talk openly about the partner and about her difficulties, show affection to the patient, to her partner. And pharmacologic, there's some types we can use. We can avoid digoxin and thiazide as possible. Use nebivolol or metoprolol, not propanolol for treatment. Use eplerenone instead of spironolactone. It's the same thing, same doses. Sildenafil has advantages to depression also. Non-pharmacological measures for breast cancer. Psychology is the best option, okay? You have to talk to your partners, show some understanding, and Philimbra has an option with mastectomized patient. Pharmacological measures too. Venlafaxine is the only antidepressant approved. Lubrificants, water-based, and ondansetron because of the nausea, like the chemotherapy. Here, next, I'll show some words of my patients. Women said, I felt like a monster. How could my husband look at me feel this way? Now I'll feel more confident and closer to him. I know the importance of talking about sexuality. We don't need to feel shame. The man. I was so tired, I couldn't breathe and feels less like a man. Now I'm getting better. I know I'm not the young boy I was anymore, but now I see it's not this heart condition that will keep me from living. Both of them was ashamed to talk about sexuality in their consultation. Here, I show some results of the hospital anxiety and depression scales. We can see some really improvements for the first consultation. From the last one we have, they still are being followed in the palliative consult, but they're still getting better. With conclusions, terminally healed doesn't mean completely loss of quality of life. And we have to talk our patient as a team, doctors, nurses, therapists as one. There's a lot to do as health professionals, but above all, as human beings. About palliative medicine, well, I bring this sentence, I really like it. We say, give life to days and not days to life. I want to thank a lot for your time, and most of all for our patients. Okay?
Thank you very much. We go from one specific type of physical activity to physical activity in general with a presentation called Active Steps.
It's not this one. Can I change? Sorry. It's this one.
Is it wrong?
Sorry. Okay. Good afternoon, everyone. My name is Mariana Moura Relvas, and I am a GP trainee here in a healthcare unit in Oporto. I would like to thank the organizing committee for accepting our intervention project that's called Active Steps, New Steps for Health. Maybe I should just, okay. So we all know and we're all aware of the impact of the cardiovascular disease in our patients' health. It is the main cause of mortality here in Portugal and also in Europe. It is estimated, has a global estimated mortality rate of 30% in 2013. There are many risk factors that we can change. The main ones that we see in our patients in our daily basis are dyslipidemia, smoking, sedentary lifestyles, and those are the ones we should insist upon change. That change can be achieved by reinforcing the beneficial effects of physical activity, like the reduction of cardiovascular disease, blood pressure. It decreases the risk of depression and also in cognitive impairment. The standard recommendations for the adult population are 150 minutes per week of moderate activity. In the elder, we should also train for functional capacities such as flexibility and coordination. With this in mind, our main goal was, with this project, to raise patients' awareness for the practice of physical activity and its importance in the control of cardiovascular factors. Risk factors. We also had some specific goals, namely to promote the initiation of moderate physical activity and to stimulate the continuous practice of it, to increase the knowledge regarding the impact of physical activity, and also to promote the control of cardiovascular risk factors. We had, in our intervention, the target was all patients that were registered in our healthcare units that were willing to participate and had at least one cardiovascular risk factor or a high cardiovascular score. The recruitment process was made by essentially invitation by the family doctor or nurse. We also placed leaflets and posters in our healthcare units. And in the previous week before the outing, our outing, we made a phone call or email to the patient to confirm that they would be present. We started on the July 1st and until September. We scheduled 8 outings, and in each one we had one specific theme that was addressed. Of a healthy lifestyle. We talked about healthy eating, salt and sugar consumption, cholesterol and its effects, some principles of physical activity, the importance of stretching, physical activity specifically in the elderly, and also the importance of keeping hydrated. Our interventions were held in several groups, and for each session we prepared a small knowledge questionnaire regarding the theme that we were talking about that day, and we then started the outing. Before and after each outing, we did some stretches, some preparation exercises, a warm-up session, and after the outing, we always gave a piece of fruit and water to our participants, and then we gave a small oral presentation of about 10 minutes regarding that theme, accompanied by a small leaflet with written information that they could read at home. Although we didn't always have the same participants in each outing, we always had fun, and we always made sure that everyone was working out at their own rhythm, because we had a lot of elderly patients. We had a total of number of participants of 27, with an average of 12 per outing, a mean participant age of 63 years. Most of them were male, but it was fairly equal, and most of them had limited education, about 6 to 9 years. Regarding cardiovascular risk factors, most of them had at least one, and diabetes and overweight hypertension were the most frequent ones. Most of them had no previous exercise done, and most of them considered to lead a healthy eating with fruits and vegetables on a daily basis. Regarding the correctly answered questionnaires, there was an improvement, meaning that they had more knowledge after the session was over than before. We identified some limitations of this project, namely a short intervention period, a limited frequency of the outings, about 2 per month, small number of participants. Some participants already had physical exercise, and some others. As positive outcomes, the bonding between participants and the bonding with our patients was very important, the encouraging of healthy lifestyles, motivation to exercise, improving general well-being, and also it helped fulfill time in some of our retired patients. For the future, we would like more participants, more involvement, more motivation, and more health in general. So thank you very much. This was what we wanted to present today.
You can stay up here. I would like to ask our presenters on the stage, and we can address any questions that arise from the audience. Anybody has a question already? No? Is this on? Yes, it's on. Okay. I have a few questions. I have many questions. Maybe I start with the last presentations that are so fresh in our minds. I really liked the idea of the taking a companion with you and everything. It's because you also addressed another risk factor, which is loneliness, which is also a very important risk factor. Do you plan a long-term follow-up and see how these patients did after these interventions?
The first time we had this project was 2 years ago in 2015. It was a bit different. It was more for only the diabetic population of our healthcare units. but we decided to broaden the spectrum and just for all risk factors, namely cardiovascular risk factors that could be changed through physical activity, as we've seen. There are many. And also because we have a population that has a lot, one of the main issues in our ASES, I don't know how to translate, it's like our groupment of healthcare units, was mental health, namely depression and anxiety. So we also think that physical activity improves this in people, and also in the elderly, it helps to take them out of their environment, being at home alone, and mingle and be with other people. Regarding what you've asked about the follow-up, we intend to continue this project next year, and we always try to better it, to find what were our limitations, what can we improve, what positive aspects do we want to keep. And during our own consults, we didn't have a lot of people, only 27 from about 6 maybe different healthcare units, so it's not a lot. But the ones that did come always ask us when there's going to be more, if something is going to happen next. So they keep interested in this, and they also tell us, you know, doctor, I've been trying to eat more fruit, or I've been trying to eat with less salt. So we always get a positive feedback from the people who participated.
Thank you very much. Any questions so far from the audience? No? Then, oh yeah, Andre, please. Maybe you just shout it out and I'll repeat it.
Yeah, I have a question for the presenter with alternative and complementary medicine. So 2 questions. First one, bundling complementary and alternative therapies for me, that's always a bit of a problem, isn't it? Because complementary would mean somebody eating nuts with their chemo. Alternative would be taking chemo instead, taking nuts instead of the chemo, right? So do you think there's a problem? We always bundle those together. Should we bundle them together? And the other question would be, what are your thoughts on us doctors as having the ethical principle of saving time and money for our patients, and then saying, this is complementary medicine, there is no evidence that it helps. Save your money, save your time. Should we do that, or is that not our job? All right, thank you.
So answering your first question, so it's true that when we say, many times we say alternative therapies, and we mean and when we are saying that, we mean complementary and alternative therapies. And for us, it's important to know if the patients are taking their teas. Many patients have herbs from over the counter, and it's important for us to know if they are taking traditional medicines, or if they are only doing the alternative ones. I don't know if I answered your question. If
It's a bit different. It's just like, why do you think we always talk about both complementary and alternative?
yes.
They're completely different things.
No, but I made here the distinction because that distinction exists. It's important if people only go for the alternative therapies. But it's true that when most of the times we use these as together. So they all mean that the patient is taking something that is not part of the conventional treatments. So the second question, sir.
Second question would be, a lot of times we have patients that are not socially strong.
Mm-hmm.
And is it our job to tell them more about how non-proven complementary medicine is?
So
Is it our job to tell them, look, this costs a lot of money, it takes a lot of time, it doesn't help, or should we just be quiet?
no, I think what the idea I tried to convey in my presentation is that we need to be able to educate our patients and guide our patients. So, but before that, we need to really learn about it and study about complementary therapies. So I don't know if you are aware, but the Cochrane Foundation has a specific website just for complementary and alternative therapies. And if you look at them, it's true that most of these therapies have no scientifically proven effect, but some of them have. So for instance, in cancer patients that use meditation, it's true that meditation can improve the quality of life of our patients. So I think we need to also to fight a bit as family doctors, we need to fight a bit about this concept we have that everything that is not on traditional medicine, it doesn't work, and it's so. There are some studies more and more showing that some therapies have effects, especially these ones based on relaxation, meditation, improving the health of our patients. But I think you're right when you say that if a patient is taking pills that have no scientific effect, that it is our job to alert our patient and to tell him that maybe it's not the best option and that there is no proven effect for that. But for us to do that, we need to learn about it, because many of those kind of over-the-counter supplements, we don't really know what's in there, and sometimes patients come and say, I'm taking a name we don't even recognize. So maybe we should say to the patient, look, let's make an appointment, I will study about it, and let me try to find if there is any evidence if that medication is helping you. But there's always the placebo effect also of patients that by taking an herb feel it's making some effect. So it's a decision. Each case is a case, I think.
Yeah. Do you want the microphone? Thank you for the comment. Are there any other questions or comments from the audience? Maybe to the other talks. Then I might add a question because of the diet. I find is a very difficult topic, since it's very difficult to assess what people are actually eating. I mean, people who say they're vegetarian many of them are very well informed, but some are just not eating meat. Is there any way in our restraints with time and in the consultation to assess a diet like easily, so that I really know, is this patient missing certain nutrients?
Okay, so as family doctors, I think this is the same problem everywhere. We always have the problem of time. Actually, maybe, I don't know if it's possible in one single appointment, but I didn't find any easy way, like 3 questions that will tell you if the patient is eating the appropriate food types. But actually, you have like the recommended number of servings, and you have to know, and this is like a very long list, but you have several lists of which nutrients are, which food type contains that specific nutrient, and you have to play a little bit with it. So there are also several sample menus, and the thing is that we have the idea, and maybe this will happen sometimes, that vegetarians are just not eating meat or not eating fish or not eating dairy if they're vegans. But actually, there are several types of the considered vegetarian and vegan diets. And you also have the semi-vegetarians, which are those that say, okay, I don't eat meat, but then if they go out and have dinner, maybe they'll even eat it. The actual, like the true vegetarians and the true vegans, maybe this won't happen for all the cases, but they are very well informed, and there are studies that prove it, that they are very well informed, and they have a real concern about their diet, and so maybe you just have to make small adjustments. To have like the main worries about, for example, vitamin B12, especially in vegans, vitamin D, especially in vegans also, and to ensure that they are eating at least those amounts of servings per day or per week. So it's not easy. There's no easy tool to assess it, but it's that, okay, tell me in the last 3 days, what did you have for lunch? What did you have for dinner? Which food types did you consume? And make that diet history. Maybe this won't be possible in a single appointment. Of course, this should also be very well planned, because this is difficult if a pregnant woman arrives and we have to take care of all of it in one appointment. This should start at preconception. Okay, you're planning to get pregnant. Okay, so what are we going to do? What do we have to worry about? And to talk about this with our females that are planning to get pregnant maybe in 2 years, let's imagine. Okay, let's talk with them and see if everything is correct and start to educate them if there are any doubts, help them really. But I think as complementary and alternative therapies, the main thing is that we don't know a lot about this. So it's hard for us to assess an omnivorous diet, and maybe it's harder to assess a vegetarian or vegan diet.
Thank you. Anybody wanted to come? Oh, yeah.
How do you deal with specific risk of pregnancy about hysteria and toxoplasmosis, specifically for this kind of patients? Because it's more difficult, I think, I imagine, to follow strictly the rules about preparation of meals for during the pregnancy due to this.
Okay, so I think that I didn't think about it before, I'm going to be honest, but I don't think it will be a problem, because even with an omnivorous pregnant woman, you won't say, okay, don't eat lettuce, or don't eat not something like some vegetable and cooked. You'll just alert her to, okay, prepare it properly. And like I said, vegetarians or vegans are more concerned about their diets than omnivores. Okay, not maybe all of them, but usually they are more concerned about these things you have to care about. I really don't see it as a problem. I think it will be the same as other types of diets, to take care about the way you prepare food, especially vegetables and fruit. So I don't see it as a problem, really. I don't think it will be hard.
Any other questions? So then, maybe a question for you. It's a very difficult topic, I find, for me personally, in a consultation to talk about sexual health. I don't have any training at all about this. I don't know how it's about you. Who of you had training in sexual health? Oh, quite a few, not bad. So is there any specific training for sexual health and palliative care that you did, or that you maybe give your colleagues, or is that something that should be advocated more?
Thanks for the question. I have training in palliative care, and when we've been training in palliative care, there's a specific topic about sexuality in palliative care. And why I would do that? Because I have written some studies, and all of them, all the professionals have shame in talk about with their patient about sexuality. Palliative patients have shame to talk about their doctors about sexuality, most because of because of their self-image. For example, men who can have an erection. Okay. They feel dyspnea. They can do nothing. They are ashamed to talk about their doctors. They are ashamed to talk about their partners. Okay, In all the studies, there wasn't one single study that put all together. Okay, we have a few studies to talk about sexuality in cardiac heart failure. We have one or two studies to talk about sexuality in pulmonary disease. More studies to talk about sexuality in oncologic patients, but not one only will talk about the patient as a whole. Okay, and in palliative care, we have to see the patient as a whole. That's just the train. The train we have in our training as palliativist, and the train we can do home.
We can always do more in training. Anybody else has a question? Then I can just quickly follow up on this. Maybe the same factor that I mentioned before was the time in consultation. I imagine that a consultation about sexual health is very time consuming, and since it's two people involved, usually the couple, and it's a very difficult topic, do you plan it outside of your usual consultations, or is it something that you do in the usual schedule on a Monday morning?
In the palliative care consultation has a different time. We have 30 minutes for our patients. The first consult should have 45, but we can do the 45. Okay, but we're trying to do our best in 30 minutes. In this specific case, this case was real. Was a couple. He has chronic heart failure. They have breast cancer. Both are treated with palliative medicine. Okay, they have the breast cancer has already metastatic disease. The chronic heart failure has already dyspnea when the patient was dressed. Okay, he was being treated with morphine with palliative ways. Okay. In one consult, they really appear depressed, okay. And one of them have courage to talk about this, okay. And there was a consultation of more than 30 minutes. Okay, we need that time, and we gave more time for that couple specifically. Okay, not 1 hour because it's difficult, but. We have to prepare something at home, okay? But there's always something new in every consult, and when we see they're getting better, okay, we can do it in 30 minutes. Yes.
Thank you very much. Any other questions from the audience? So we still, officially it would be like finished now, but we still have a little time if we want to, because it's been, we started a little late. I don't know what the organization committee says. Should we go on for a little more? 20 more minutes, nice. So, that's okay. Yeah, we missed one presentation, unfortunately. Yes, there's a question. Where is a question? Oh yeah, please.
I think everybody can hear me. Mafalda, right? No active steps? Mariana, I'm sorry. It's sort of good with them. I actually have a similar project to yours. It's called Our Corda aos Ténis, which is a tongue twist with sneakers, shoes. And I have a problem with sponsorship. So I would like to ask you, how did you deal with this?
Pretty basically, we sponsored ourselves. So we were a group of 10 GP trainees. So we just divided the costs by everyone, and it was pretty cheap because maybe the print of the posters and the flyers was a little more expensive, but it was black and white, and sometimes we would just do it at home. And the water and the fruits, we just bought them in the supermarket. And since it was twice a month, it was 8 sessions, so it wasn't a lot of money involved. So we covered the costs. But you should start if you want funding for this kind of projects. You should start by large supermarket stores like Continente or Jumbo, and ask them for water or fruits, because I've done that in the past for other events, and they give you things, or call like water companies to see if they can give you water bottles, and you'll sponsor them in the flyer or the poster or whatever. And most of them are pretty okay with doing it, so just go for it.
Maybe I also have another question to your project. Since this is more like of a community-oriented primary care project, so you go out to your patients and try to give them more skills to live a healthy life, basically. Since usually the knowledge that you give the patients is not necessarily academic, do you think it needs to be a doctor who does this kind of stuff, or could it be someone else who does this as well, and maybe like free your resources a little bit?
So we chose to do it ourselves because we wanted to cover a lot of different topics, and mainly because we did try for a few topics like healthy eating and physical activity. We tried to contact. We have in our healthcare unit group a nutritionist that's available, but or maybe two, but she's one. So we tried to reach her, but she wasn't available to do these kind of sessions. And we also have a physical therapist, but I think he came to one of our sessions, yes, to the stretching exercises session. So we always try to bring people that are not exactly ourselves, because we are not the best and most informed people regarding all of these topics. Obviously, we know everything superficially, and we all had to study to make the flyers, the leaflets, and the posters, and all the information we wanted to give. We had to study that previously. So, but in another way, because they are our patients, I think that there's a connection that will stay beyond these sessions, that they would not keep with the nutritionist or a physical therapist or other people, even though they would be more qualified to maybe give the presentation. Because we did something, as you can see, most of our participants had a very low educational level of about 6 to 9 years was the average. So we had to always adequate the way we talked. The written information that we gave was always in a very different, not scientific language, obviously. It was very practical language, and our sessions didn't have like a PowerPoint presentation, or it was just orally, like we were just talking, interacting, asking questions, and people would respond and ask you questions. So it wasn't like we were there blurting out everything we knew about salt consumption or sugar consumption. And it was interesting because I think it was much more fruitful for us, because not only for us but for the patients, because they were able to actually ask us what was on their mind. I didn't know that like we all were only supposed to have 5 grams of salt a day. I usually, maybe if I do it the dosage by hand, it will probably be 10 or more. So it's like specific things, little things that are also very typical of Portuguese people, that we were able to change. So it's not like nobody's going to run the marathon. Maybe like 1 or 2 will probably try. But small things, I think, were achieved, and I think that was the important part of the project. I don't know. Did I answer the question?
Yeah.
Yeah.
Thank you. There is a question where? Oh yeah, please.
I just wanted to say something. I think your project is really interesting, but at the same time, it makes me sad and angry because you have to pay for it. And that kind of project, I think that we have to stop doing things like that. Because if we keep doing things like that, government and founders are going to say, you're doing it, so why should I put money in it? Because you're doing it. So at some point, we have to say, like, that's your problem with the funding. Like, in my practice, we have a special nurse who is paid
Amen.
I think we have a little different perspective because we are going to present our results as we did in 2015. Our colleagues presented the results they had to the ASES, yes, the group of health centers. And they have the ability to, with those results, if we give them positive results, I mean, it has to start somewhere. If we're not happy with our conditions, we need to do something to change it. And here, obviously, we had a very controlled budget, so it wasn't like we were spending millions. But I agree with you in one point and disagree in another, because I think we need to keep doing these things, because one, it's bonding for us and our patients. Two, it's some way of doing something positive for someone, which is, I think, is also a part of our mission as general practitioners. And I know that the ideal would be to have this funded by government and or have this done by specialists and not waste our time doing this, because this was done by us in our free time and the patient's free time. So obviously it took some effort to do, but I think that you need to look for funding, maybe that not in the government initially, like I was telling the colleague there, which I have done for other projects or even medical events, and you'd be surprised how many positive answers you get, especially if you do it locally, or if you do it like in a distant location and go for the local markets. They are very open to this kind of initiatives. And then when you have something going and you have results, then you have to polish it up and present it to the government facilities so that they can see that this works, that they need to improve and do more of these projects instead of just giving out documents about healthy eating and salt consumption and things that the public doesn't even know that exist, and do more things like this. So I think agree and disagree, yes.
Regarding that, I have a problem with continuity because I'm doing, we are doing, there are 7 of us in Cascais, and we are doing 2 walks per week since September 20th, and we need to maintain it through 2018. And if we don't have help, outside help, I don't think that we will be able to do it at least twice per week. And I presented the project a few months ago to my ASES, and they were all very happy with the project. And then I said, well, but we are doing this in our free time. We have 2 more hours per week doing this. Can we put this activity in our schedule? Well, no, not for now. And can we have any money to print T-shirts, print color leaflets and posters? Well, no, not for now. And so that's why I asked the question I did.
Well, I think your assess is really not good, but but maybe you can try at this point that you've had September, October, November, December, 4 months of intervention, gather like primary evaluation, see what, if you have achieved, probably have some goals set up for this, see if you have achieved any of those goals, and bring it back to them and say, see, we are doing this, we are spending our money, we are investing in this, and this is working. So I think that you need to be more interested in this, and you need to help us with resources. And if you can't get the ASES to give you resources, then try City Hall, try politics, try supermarkets, try, when we started this, we started trying to get funding from all of those different locations. So the thing is, you have to persist and never give up, otherwise they're gonna forget that you're doing that. So you need to keep remembering them. So, or maybe even send pictures, take pictures of the walks and send it to them. You know, in a way of remembering that, you know, we're doing this for the community, and it's also your role to improve things in the community. So why can't we do it together? I think maybe.
A heated discussion. I hate to break it up, but maybe you can continue it in the break that we have until tomorrow. I think it's time for us to close this session. I want to give a big round of applause to the presenters who took a lot of time and effort for these presentations. Thank you very much. And I wish you all a wonderful evening with the wine tasting that I think is going to follow. And see you around. Enjoy the rest of the conference.